Hello again. I'm Ryan Carnahan, a psychiatric pharmacist and epidemiologist at the University of Iowa College of Public Health. This video is an addition to our original series. It's intended to orient you to changes and regulations that apply to antipsychotic medication use in residents of nursing homes in the United States. On November 25, 2014, the Centers for Medicare and Medicaid Services, or CMS, posted a transmittal detailing revisions to the State Operations Manual, Appendix PP, Guidance to Surveyors for Long-Term Care Facilities. A number of these revisions applied to care for residents with dementia. The purpose of this video is to review the changes that relate to antipsychotic use in nursing home residents with dementia. Providing care that's consistent with this guidance is not only important to ensure quality care for residents, but it's also because it can impact nursing homes through citations, fines, and quality ratings. I should note that I won't be reviewing changes proposed by CMS in July 2015 that comprise a significant update of regulations for nursing facilities. At the time of this recording, these rules are still only proposed and are subject to comments and revision before they're enacted. The final updated regulations are yet to come. Most of the new guidance for surveyors on dementia care and antipsychotic use is very consistent with the approaches we recommend in our lectures and resources. It stresses the importance of thoroughly evaluating the causes of behavioral and psychological symptoms of dementia, as well as using individualized, person-centered approaches to care to help manage these symptoms without medications. Some of the person-centered care strategies that are highlighted include eliminating triggers of negative reactions, altering the environment, introducing personalized, meaningful, and enjoyable activities, changing approaches to care to match the resident's preferences, and ensuring that direct care is provided by staff who are familiar with the resident's needs and preferences. The guidance provides an excellent overview of various factors that may contribute to behavioral and psychological symptoms of dementia and is a worthwhile read for those providing care to people with dementia. Specifically, it states that antipsychotics may be considered for individuals with dementia only after physical, functional, psychological, emotional, psychiatric, social, and environmental causes of symptoms have been identified and addressed. Target symptoms must not be due to a medical problem, medication side effects, environmental stressors alone, or psychological stressors alone, and must be persistent. At its core, this guidance attempts to prevent the use of antipsychotics for problems that could be solved by eliminating the causes of the symptoms, or by use of other less risky interventions. This guidance also includes changes to the criteria by which surveyors determine whether antipsychotics are appropriate or inappropriate for a resident of a long-term care facility. The new guidance is generally more restrictive, so we felt that it was important to provide an update and revise our clinical decision aids to make them consistent with the new regulations. New versions of the antipsychotic pocket guides are now available on the website. Laminated copies of these updated guides can be ordered, and the mobile device application on this site has been updated to reflect the new regulations. I'll be focusing on antipsychotic use in patients with dementia in this overview. However, there are a number of other medical conditions that can justify the use of antipsychotics. These include mental health conditions that produce psychotic symptoms, severe mood disorders, psychosis related to medical conditions or treatment, such as those occurring in delirium, Tourette's disorder, Huntington's disease, hiccups, and nausea and vomiting related to cancer or chemotherapy. The impact of these conditions is still required to meet a specific set of criteria, including dangerousness to self or others. I'll describe these new criteria in more detail shortly. In dementia not complicated by one of these other conditions, the potentially appropriate target symptoms for antipsychotic use aren't as clearly stated as in previous regulations. Based on the contextual information that's provided, however, I believe the potentially appropriate treatment targets remain essentially unchanged. Hallucinations, delusions, and aggressive behavior are the target symptoms that seem most likely to meet the new criteria for appropriateness. Regulations aside, I'd still consider these to be the most appropriate target symptoms for antipsychotics in people with dementia. These fit with the typical symptoms targeted in the clinical trials and are most likely to justify use in the context of the significant risks of these drugs. Some of the most notable changes in this guidance, in my view, are in the criteria that relate to how the impact of a symptom is used to justify antipsychotic use. The old criteria allowed antipsychotic use when the target symptoms presented a danger to the patient or others, or if the symptoms caused the patient to experience inconsolable distress, a significant decline in function, or substantial difficulty receiving needed care. The new criteria are quite different in that they exclude this second category. Persistent distress, decline in function, and difficulty with needed care are no longer part of the criteria. The core criterion for any antipsychotic use is that the symptoms must present a danger to the resident or others. This is necessary but not sufficient to justify antipsychotic use according to the new guidance for F329 citations, which relate to unnecessary drugs. In addition, the symptoms must meet one of two additional criteria. The first option is that the symptoms are due to mania or psychosis. Mania occurs in people with bipolar disorder, a major mood disorder which has a course that usually begins by early adulthood. Mania is characterized by symptoms such as an increase in energy, irritability, pressured speech, limited need for sleep, grandiosity or excessive self-confidence, impulsivity, risk-taking behavior, and sometimes psychosis. Some of these symptoms can occur in a person who has dementia but no history of bipolar disorder. This doesn't necessarily mean that the person has bipolar disorder. Manic symptoms such as hyperactivity can also occur in other conditions, including delirium, and can be caused by certain medications such as corticosteroids. Psychosis has been discussed previously. It typically refers to delusions or hallucinations. Delusions are fixed false beliefs. Often the content is paranoid, such as someone being out to get the person, a spouse being unfaithful, or people breaking in to steal or hide things. Hallucinations are sensations that seem real to the person but aren't based on real stimuli, such as hearing voices or seeing people that aren't there. It's of course important to determine that these aren't real or aren't just misinterpretations of the environment that have to do with sensory issues. Hallucinations or delusions are often diagnosed in people with cataracts or other visual problems, for example, because they contribute to misperceptions of things in the environment. If the antipsychotic is not being used for mania or psychosis, but rather for aggressive behavior resulting from agitation, then the criteria state that behavioral interventions must have been attempted and included in the plan of care. The assumption is that these interventions have been tried and documented, but have been unsuccessful in alleviating the dangers to the resident or others. These behavioral interventions should be continued even with medication use, and reasonable attempts to decrease the dose or discontinue the antipsychotic should be made with support from behavioral interventions. Interpreting whether a symptom is dangerous to the resident or others is clear in some cases, but not in every case. A resident who regularly strikes out at caregivers or other residents is clearly dangerous to others. Even in those cases, it's important to try to identify and address underlying causes, such as pain experienced when cares are provided. But the case can be made for antipsychotic use if other interventions are unsuccessful in curbing this aggressive behavior. Verbal threats such as yelling at others and threatening to hurt them could also be considered dangerous to others, even if no actual physical harm has taken place, assuming there's a legitimate risk. This is perhaps less obvious, but civil commitment laws generally consider threats of harm to be enough to force involuntary psychiatric treatment in a person suffering from a mental condition, because these threats demonstrate dangerousness to others. I would expect the same interpretation to apply here. A symptom could be considered dangerous to the resident under a number of circumstances, either in cases of direct self-harm or sometimes in impeding care necessary to the resident's well-being and consistent with treatment goals. A delusion that the food is poisoned, such as that experienced by Mrs. Klein, that leads to the resident not eating, can lead to harm by way of starvation, so I think that an antipsychotic could be well justified. Delusions may also lead to attempts to elope from a facility, such as by a resident who thinks she's left her children unattended and needs to go find them because they're in danger. If elopement is a real possibility, that could lead to harm to the resident and may justify antipsychotic use. Direct self-harm might also take place. For example, residents may have delusions that they're infested with small organisms such as lice or worms, scratch themselves to the point of injury to try to remove them, and then perhaps keep scratching and worsening the wound. An antipsychotic may be justified in this case. I also believe that there's some gray area in the guidance, so my hope is that reasonable standards will be employed on a case-by-case basis when surveyors evaluate the use of antipsychotics. The revised guidance for citations around dementia care quality, the F309 tag, describes the patient I mentioned earlier who has persistent emotional distress and is inconsolable because she has a frightening delusion that she's left her children unattended and they're in danger. In the description, this delusion failed to respond to staff and family attempts to address the fear. No specific behavior that would place her or others in danger is described, even though dangerous behaviors could potentially result from this delusion. Despite the lack of a description of any specific dangerous behavior, the guidance says that an antipsychotic may be warranted. To me, this sounds like an example of severe and persistent distress resulting from a delusion, and my personal opinion is that an antipsychotic may be warranted to try to ease this patient's suffering, even if no obvious physical harm is resulting. I've spoken with surveyors about this and received feedback that psychosocial harm resulting from these persistent symptoms could potentially be used as a justification for antipsychotic use when other interventions fail, even if the potential for physical harm is unclear. They stress that thorough documentation is key in their evaluations of whether an antipsychotic was justified. In contrast to this, there are also cases in which people with dementia experience hallucinations or delusions that are not particularly distressing to them. There's really no reason to treat these since they aren't distressing. Disconnection from what others perceive as the current reality is also very common as dementia progresses, and this should not be misinterpreted as delusional thinking that's in need of antipsychotic treatment. Better outcomes are achieved when caregivers go along with the experience of a person with dementia and provide positive reinforcement, or distraction if needed, rather than challenging the individual's perception of reality, which can lead to distress and conflict. Another complicated aspect of the new regulations is that these same criteria for impact of symptoms also appear to apply to antipsychotic use in people with severe and persistent mental illness, or other indications in which antipsychotics are part of the standard of care. To require that people with schizophrenia, for example, exhibit behaviors that are dangerous to themselves or others in order to continue to receive antipsychotics, which they may have received for the majority of their lives, seems that it could expose these individuals to a great deal of unnecessary suffering. Relapses of acute schizophrenic psychoses can be devastating. If someone with schizophrenia is stable on their current medication regimen and has no significant side effects, then it's difficult to want to change things to test if they'll relapse or not. This is a chronic condition for which long-term antipsychotic treatment has been shown to reduce relapse. In contrast, the target symptoms of antipsychotic treatment in dementia often resolve over time, so that an antipsychotic provides no further benefits and only puts the person at risk of side effects. Collecting a good long-term history could help justify antipsychotic use in schizophrenia. Any past acute psychotic episodes in which the person was dangerous to themselves or others would support the idea that discontinuation of the drug could lead to these same dangers. A caveat to this is that there are some data suggesting that, as people with schizophrenia age, the same dose may lead to higher blood levels because of the changes in metabolism and elimination that can occur with aging. Gradual dose reductions may be warranted in some of these patients given these changes. However, I'd advise that doses be reduced very slowly in nearly all cases in order to reduce the risk of relapse. A goal of no antipsychotic is unrealistic for most patients with schizophrenia. Slight modifications were made to the language in the surveyor guidance describing inappropriate antipsychotic treatment targets, though the message remains essentially the same. The new criteria are shown in orange on this slide. One addition to this list is insomnia. Antipsychotics are overprescribed for insomnia in my opinion, particularly low-dose quetiapine. Impaired circadian rhythms are common in dementia, but often residents who are awake at night can be accommodated rather than trying to use a drug to make them sleep on a schedule. This is an advantage of having 24-hour staff in nursing homes, whereas accommodation may be more difficult if family provides care at home. Another addition to the inappropriate indication list is sadness or crying alone that is not related to depression or another psychiatric disorder. I assume this was added so that normal non-pathologic human emotions aren't used as justifications to give a person an unnecessary drug. If the sadness or crying is persistent and stems from major depressive disorder or severe anxiety, then behavioral and possibly medication treatments for depression or anxiety may be warranted. If it relates to delusions, then that may change the assessment as well. There are several other important changes in this guidance. I've already mentioned the first. The other causes of behaviors must be ruled out and symptoms must be persistent to justify antipsychotic use. A one-time incident may justify emergency treatment, but it doesn't justify long-term use of an antipsychotic. I've also mentioned that non-drug behavioral interventions are expected to be implemented and included in the care plan, and should be tried prior to using an antipsychotic for persistent symptoms. These should be continued even if medication is used, with the goal of reducing and eventually eliminating the need for an antipsychotic. The new guidance also highlights that any emergency use of antipsychotics should lead to an interdisciplinary evaluation within 7 days. The purpose of this evaluation is to fully explore potential causes of the symptoms that led to antipsychotic use, to update the care plan as needed, and to ensure that antipsychotics aren't continued long-term for problems that aren't persistent or could be addressed using other interventions. Finally, the new guidance highlights the need to evaluate antipsychotic use in residents who are admitted on one of these drugs. This should take place on the initial minimum dataset assessment within 2 weeks of admission. A good history can hopefully help determine whether an antipsychotic is still justified, or whether it may be time to consider a gradual dose reduction or discontinuation of the drug. I'd like to take a step back for a moment and consider this guidance in the larger context of caring for people with dementia. The general principles outlined in this guidance are completely consistent with best practices that one would hope would be applied in any setting of care, not just in nursing homes. However, I have some reservations about the requirement that a person has to be dangerous to themselves or others in order to justify antipsychotic use. I appreciate that this requirement may help reduce unnecessary use of these medications and that the side effects are of serious concern. I also think other medications may be safer first options in many cases, such as acetaminophen if pain might be contributing to the stress. SSRI antidepressants may also be helpful for agitation, and I prefer their safety profile to that of antipsychotics for many patients. More information about these other medications can be found in our evidence-based review on antipsychotic use in dementia, which is posted on this website. However, a patient who is severely and persistently distressed because of delusions or hallucinations, and for whom other interventions have failed, still seems like a reasonable candidate for antipsychotic use, regardless of whether safety is clearly compromised by the symptoms. I would not want to see people suffer unnecessarily because of strict regulations, however well-intentioned they may be. My hope is that in these cases, surveyors will focus more on the process by which it was decided that the antipsychotic might be helpful, as well as the documentation of that process and the rationale that led to the choice. Surveyors I've spoken with have endorsed that documentation is key in their determination of whether a citation for unnecessary drug use should be issued, and that a physical danger to the resident or others isn't necessarily required to justify antipsychotic use. If a good evaluation was done, behavioral interventions were attempted, symptoms were severe, persistent, and destructive of life. That brings us to the revisions to the pocket guides. The revised portions of the pocket guides for both direct care providers and clinicians are shown here in the boxes. We made revisions to Bullet 4 describing justifications for antipsychotic use, as well as the sections listing appropriate and inappropriate indications. Bullet 4 highlights the dangerousness to self or others criterion for residents in nursing homes, but also includes our group's opinion that an antipsychotic may be appropriate in other situations if it improves the patient's overall quality of life. I hope that this has been helpful in understanding the new regulations around antipsychotic use in nursing home residents with dementia. Thanks for listening.